Think Dr. Kamal Kapoor, sir. He is the director of and founder of Sharpsight Center and one of the most dynamic surgeons that we have ever seen.
Very good morning, Dr. Chitra Naga. Thank you for having me for this course. I think this is actually a hot thing for most of people are calling me for is Phakic IOLs. Uh, okay, just a minute. Yeah. So the finer nuances of Phakic IOLs and the preferred practice techniques. Uh, there are so many options available in the market. I'll go very fast and just zone in onto the relevant part. My main experience is with the IPCLs. I probably do have the highest experience in IPCLs. Of course, I do a lot of ICLs also. Case selection and sizing up is the main cornerstone of doing a good surgery. Technically, the surgery is not difficult at all. Any good phacosurgeon can practically master the surgery. Practice guidelines, what I follow in my practice would be, excluding myopias, you have to look at these patients with a distant direct ophthalmoscope, because a lot of times you might miss early sclerosis on a slit lamp. Any evidence of slight development of cataract, if it's a developmental cataract, please notice and mention it in the file. Inform the patient, because these cataracts most of the times are non-progressive. But if it's a central sclerotic cataract, it is going to progress. Corneal endothelial counts, beginners should restrain going below 3 millimeters to start with in the anterior chamber depth. Always look for the lens rise. This is a new concept which I've introduced over last 2 years, and it's really helping a lot of my colleagues. You have equipment which can actually measure lens rise. We will go to that. Look for pupils which do not dilate properly, because if the pupil is not dilating properly and you have a cornea which is 12, so you'll be going in for a size of 13.5, you're gonna have hell of a trouble putting this lens through a 8 or 8.5 millimeter pupil. So beginners should refrain from going in for pupils which do not dilate well. Number two, if your resting pupil size is too big, be careful, because in a standard practice, we are not taught about measuring the pupil size. So as a standard practice protocol, mention your scotopic resting pupil size also, and also mention how much does your pupil dilate when you dilate the pupil, because this will actually help you plan your surgery, size your lens, and actually plan your optic size. Very large pupils in my practice, any pupil size more than 7.2 is marked as large pupil on the file, and the order is given for a larger size optic. Keratoconus patients, you have to be very careful. These can be very tricky, because in the keratoconus patient, you can have a false anterior chamber depth which is high. Please measure and note the angles. Have a gonioscopy, measure the angles on an ASOCT, document it, and I would also recommend doing a PI in keratoconus patients, because I've burned my hands in patients where everything seemed fine, but then there was an erroneous vault which was totally unpredicted. So I have a large series of surgeries and long follow-up. I'll just skip this. So the practice of workup is that dilated acceptance, cycloplegic acceptance of these patients. As Dr. Himanshu Matalia said, because a lot of times you would have a patient who's wearing -9, but his refraction is 7. But he's just been accommodating because somebody gave him wrong glasses. So you will land up in trouble. Do a cycloplegic acceptance. If the astigmatism is more than 3 diopters, always measure the vertical diameter also. This will help you to plan the optic size and the vault, because if you go for a larger optic size, you will have higher than expected vault. Anything between 150 to 250 microns. So if you have a higher astigmatism, especially if your vertical axis is steeper, please mention that. It's a good idea to do an axial length also and document it in your file. God forbid these patients may have retina detachment. These are high myopes. So at that point, you want to do a cataract and silicone oil at the same time. So it's a good idea to do a biometry and document it. As I said, keratoconus, always be very, very careful. Gonioscopy, specular macroscopy, as I said, biometry is very important. So make it as a standard protocol. It's the workup which is most important. The surgery is over under 2.5 minutes. So this is a very, very important point. So what are the break points you will have? If you are a person who uses a pilocarpine at the end of the surgery, expect a lower vault from anything between 200 to 300 microns lower for first 1 or 2 days. So don't get psyched up. If you've used a myotic and you're seeing a vault of 300, 400, relax, you will get 500 to 700 once everything goes. Look for IOP rise within first few hours of the surgery. This is a standard protocol I recommend to all my friends, because especially if you're a beginner surgeon, you might end up leaving some viscoelastic there and you'll have a pressure spike within first few hours. So if you see this patient, put the patient on slit lamp, put a little bit of paracaine after a few hours, and use the needle to burp from the side port. If you see any opacity in the phakic lens area, don't be alarmed, especially within first few weeks. This is not cataract, this is retained viscoelastic. All you need to do is do an ASOCT, find out what it is. If you have extreme of anything, very flat cornea, very steep cornea, plateau iris, a high lens rise, watch out, because these patients will behave differently. So as I must mention, pupil size is very important. It is not stressed by a lot of people who are doing phakic lenses. My long track record, I've realized pupil size plays a huge role in your patient satisfaction. So, time over? Okay, fair enough.
No, anything to add, conclude, you could conclude, because it's
Okay, so there are two major options. You have 0.25 decimal size variations in the IPCL. You have 0.5 in the ICL. I prefer playing with very, very fine tuning, so I prefer tilting more towards the IPCL, especially in situations when you have 11.1 and 11.15. What do you do? But when you're operating on an IPCL, you can play with 0.25. So you can probably have a very high vault in one eye and a normal vault in another eye if you're going with an ICL, because just a 0.5 measure here and there, 0.05, can make the whole thing go haywire.
Excellent talk, Dr. Kamal Kapoor. I would like to ask you a question. What are the factors that you think would cause a rotation in the ICL or the IPCL?
Very interesting case. I was just discussing yesterday. I had a similar session. Normally, it's a bad measure. It's a bad measure. Most of the people are using automated measure on an infrared camera, because most of the equipment we use is automated. We just corroborate it with a caliper. So recheck it manually on an edit mode, any equipment you're using. I wanted to show you some videos. I use an autorefractokeratometer, high resolution autorefractokeratometer. It gives you a very, very accurate cross check. Second thing is, I've had two patients where the vault is 900 and the lens is rotating. So when we did a UBM, we found that the zonules were lax. So everything was fine, the white to white was fine, everything is accurate, but there was so much of space, so the lens has still got a vault but is still rotating. So very rare cases, I think 2 cases in 3,000, 4,000 is rare, but you could have a bad ciliary complex and you could have a rotational lens in spite of a good vault.
Thank you very much, Dr. Kamal.